Good morning, ladies and gentlemen. My name is Mohsen Sharifi, and it's an honor to be here. I would also like to thank Dr. Craig Walker for arranging for NCBH Digital Education Series. What I will be talking about today is the important topic of whether catheter-directed therapy or any form of percutaneous endovenous intervention for DVT is necessary. Now, at the cost of having a spoiler alert, I have to tell you that the answer is a resounding yes. And by the end of this presentation, you will realize that the data supports this inference. Now, some data about venous thromboembolic disease. We know that it is the third leading killer in the United States. Over 800,000 cases are diagnosed annually. And in fact, many of them go underdiagnosed or undiagnosed. There are over 600,000 admissions per year, and the mortality traditionally has been quoted at 100,000 per year. However, recent data suggests that it can be as high as 150,000 to 200,000. And the sad point is that it is a preventable cause, yet we are facing such mortality. If there is massive pulmonary embolism secondary to development of DVT, we're talking about close to 60% 90-day mortality. And if we have submassive PE, we're still talking about a high number, around 15%. It's not just PE, which is a deadly consequence of extensive DVT. There is phlegmagious cerulea dolens, that can be a deadly disease as well. It's not just the pain and the discomfort and the swelling and the morbidity, but it has a high mortality, over 40%. And amongst those who survive, there is a high in excess of 50% amputation rate. More common, however, is venous leg ulcerations or VLUs, which you can find in 1.5% of the general population. That said, if you look at the elderly population over 65 years, you can find this at 5% or more. Now, the main pathway of the negative effects of DVT is inflammation. In reality, it's a chronic inflammatory process which stays with you, and it continues throughout the lifespan of that patient. This would lead to interstitial hydrostatic pressure elevation, which in turn would lead to ambulatory venous perforation and different causes of effect. This slide shows the fact that almost any kind of blood cells can be involved in this inflammatory process. It can involve the erythrocytes, the leukocytes, the mast cells, and a whole host of cytokines which can become chronic, and the inflammatory process continues after development of DVT. Recently, the agents, the molecules, and the proteins involved have been identified. It includes, but not limited to, ICAM1, VCAM1, the CD4 series 54 and 106. There is activation of the transient receptor potential vanilloid channels in this process. Again, any form of the cell lineage can become involved: the leukocytes, monocytes, macrophages, erythrocytes, platelets, and mastocytes. Cytokines are activated, chiefly tumor necrosis factor alpha and transforming growth factor beta, the interleukins, MMP, and the interferons. The MPRIN system is activated, and the MAPK system, the mitogen activated protein kinase pathway, is activated as well. DVT may not be found in isolation. There are conditions that have been underdiagnosed or unrecognized, such as outside pressure, external pressure over the truncal vein. This would involve tumors or the effect of the adjacent artery. The classic has been termed as the May-Thurner syndrome, but there are different permutations to this adjacent arterial pressure. Adenopathy secondary to cancer or primary adenopathy can cause pressure on the truncal vein. Radiation can damage the vein and cause DVT. There's also direct and indirect venous damage brought about by orthopedic surgery. And these orthopedic hardwares can damage the vein chronically. The effects can manifest themselves within several months or even years after. Even pelvic and abdominal surgeries can damage the truncal veins and the placement of AAA endoluminal grafts. And we'll see some of those examples as well. This is an acute presentation, somebody with extensive bilateral DVT, and this is obviously what we would like to avoid: venous leg ulceration and post-thrombotic syndrome. Now, going back to the actual topic of this discussion, whether percutaneous endovenous intervention or PEVI, which involves and includes catheter-directed thrombolysis, is indicated in DVT. Now, this concept over the last decade has had a roller coaster acceptance amongst providers. And it was the negative effect came by in 2012 and followed by 2016 guidelines in the chest. It was subsequently exacerbated by the findings of the ATTRACT trial, which was published in 2017, and recently the CAVA trial, which was published in January this year. Now, the ATTRACT trial read as its conclusion that, and I want to read this for you, amongst patients with acute proximal DVT, the addition of pharmacomechanical catheter-directed thrombolysis to anticoagulation did not result in a lower risk of post-thrombotic syndrome, but did result in a higher risk of major bleeding. So whoever reads this conclusion would say, okay, this is associated with worse outcome as far as, and yet it does not affect the post-thrombotic syndrome. And subsequent to that, and immediately after that, the European Radiology Society, they came out with the opinion that for the reasons described above, the findings of the ATTRACT trial does not reflect our practice. So there was a lot of confusion about when to do this procedure and whether it's actually indicated or not. Then came other editorials trying to clarify this issue. And recently, in relation, there was a subgroup analysis of those patients who only had the iliac component of DVT, and significant improvement was noted. However, when such a you can't unring a bell. In other words, in the medical community, which are educated people, a bad or a misrepresentation or a misdiagnosis of the findings can lead to irreparable consequences as far as the indications of treatment. Now let's go back to the ATTRACT data. As far as leg pain in the interventional group, there was a significant improvement. So bear in mind, although PTS is very important, PTS is not the only criteria and the metric that we have to look at. Leg swelling was less. So leg pain and leg swelling immediately improved in the interventional group. There was no difference in any bleeding between the two groups. Major bleeding, however, was higher in the interventional group, and you can see the significance was barely reached. Now, if you look at the subset of patients who had iliac or iliofemoral DVT, moderate to severe PTS, even defined by the Vialta score of 5 or more, which I personally don't believe it should be the metric for assessing PTS, and I'll tell you why, was in favor of the interventional group, and severe PTS was also in favor of the interventional group. Now, the Catatrial further exacerbated this misunderstanding. The Catatrial was published in January 2020 in Lancet Hematology, and the title of the study was Ultrasound Accelerated Catheter-Directed Thrombolysis versus Anticoagulation for the Prevention of Post-Thrombotic Syndrome. It was a single-blind, multi-center, randomized Dutch study. 184 patients were randomized, 91 to the interventional group, which was ultrasound facilitated using the ECO system, and 93 to the control group. However, follow-up was only 74 patients in the interventional group and 71 in the control group at 12 months. They used urokinase as opposed to TPA that is commonly used in the US, and they used it up to 96 hours. PTS at 12 months was the primary endpoint, and they defined PTS as a Vialta score of 5 or more. And they found out that PTS was in 29% of the patients at 1 year, in the interventional group, and 35% in the control group, and this was not significant. And the interpretation reads as follows. This study showed that addition of ultrasound accelerated catheter-directed thrombolysis does not change the risk of post-thrombotic syndrome 1 year after acute iliofemoral DVT compared with standard therapy alone. However, the authors go on to say that this trial is inconclusive, and the outcome suggests the possibility of a moderate beneficial effect with addition of ultrasound accelerated catheter-directed thrombolysis, and further research is indicated. Now, I have personally a lot of criticism toward this study. I do not want to get to the depth of this, but just to point out several major shortcomings, they're as follows. Nearly a quarter of the initially randomized patients did not reach the 12-month follow-up. The 12 months was the median follow-up, and the interquartile range was 6 to 12 months. And some of these patients were getting 96 hours of thrombolysis, and they were confined to bed during that time. Sick patients were excluded from that cohort. In other words, those with malignancy within 6 months or active malignancy were not included. And we have a lot of patients who need exactly this kind of procedure because of their malignancy. Those with renal insufficiency and even slight elevation in liver transaminases levels were excluded. Patients who had impaired mobility, major surgery within the preceding 6 weeks were excluded. And again, these are the patients that you get called upon because of a problem, those who cannot move. They even excluded patients who had SEEP clinical class 3 or above. In other words, if somebody had edema, which by definition, if you look at the definition of SEEP, they would qualify under this category, they would have excluded. And if patient DVT in the past, they were excluded. They included patients at set of symptoms for 2 weeks prior, and once they presented, they could have waited for 3 weeks after admission for the intervention to get started. In other words, from onset of symptoms until the actual of receipt of treatment, in some patients, 5 weeks had elapsed. Not acceptable because it's a long time, and by that time, irreparable damage be imparted to the circulation. Also, DVT involving the common femoral vein and the iliac system were lumped together. So one does not know how many of these were common femoral vein DVTs and how many included iliac vein. Also, at 12 months in the interventional group, anticoagulation was used in 49%, whereas in the control group, they were a higher rate at 61%. So there's a difference there as well. Now, I had really questions about the technique in this trial. Again, not entering the details. 60% of the 77, this is looking at modified intent to treat, had DVT, which is a high number. If you are already received treatment and you're on anticoagulation, getting this number of DVT is a high number at 12 months. And 10 of the 77 patients had in-stent restenosis equaling 13%. But this is from the whole denominator of the 77 patients. Not everybody had a stent. There were 35 cases out of the 77 who had stents. Therefore, the true stent thrombosis rate in this study is 10 out of 35, which is 29%. And they allude to the fact that half had unsuccessful stenting. So this number of 29% in-stent thrombosis in the venous circulation where you're using large stents is almost unheard of. And I've put the results between the interventional group on the left and the control group in other endpoints. These do not reach the level of significance, but uniformly are in favor of the intervention group. For example, the mean Rialto score at 12 months was less in the interventional group compared to the control group. Moderate and severe PTS were less in the interventional group. Mean venous clinical severity score was less. Ulceration was less. Pulmonary embolism was less, and death was less, although these did not reach statistical significance. On the other hand, bleeding was found to be more. So what we have to do when we are communicating to each other is to avoid misleading inferences. And I think this is what has happened in the ATTRACT trial. This is what has happened in the recent trial. And we have to be able to communicate the endpoints effectively to each other. Now, looking at the natural history of iliofemoral DVT at 5 years, historically, venous ulceration occurs in about 15%. There is a high number of venous claudication in these patients, anywhere between 15 to 40%, which is significant morbidity. Venous insufficiency and reflux is very high, approaching 90%. And PTS is at least 50% in this cohort of patients. Now, in the TORPEDO trial, we did not use the Rialto score. And this was a major criticism to us, saying you're not using the standard accepted time-honored metric for this. And this was exactly why, because somebody with edema, a little induration, a little erythema, they would be already having post-thrombotic syndrome. So either you have to look at the change, or you have to use some other metric to assess this. In the TORPEDO trial, we found that recurrent VTE, both at 6 months and 30 months, was less in the interventional group, and PTS was significantly less at 6 months and continuing to 30 months. The corresponding numbers were around 27% and 30% in the control arm. If you look at the 5-year CAVENT outcome, again, PTS was found to be significantly less in the interventional arm. The femoral popliteal reflux was also less in the interventional group. However, the patency of the truncal vein was not different amongst the two groups. You can appreciate that somebody presenting with this symptomatology can get immediate relief with intervention. So even if your metric of PTS, as defined by a Rialto score of 5 or above, is not altered, this change in the patient's condition is an important factor in his quality of life. If you look back at the older data, dating back to 1969, Cochrane review put them together and found out 668 patients would qualify for assessment. Their presentation was within 14 days of symptoms. and they included those who had femoral and iliac DVT. The type of therapy was streptokinase, urokinase, or TK, and they realized clot lysis was more in favor of the interventional group. PTS was significantly reduced. Bleeding was somewhat more, and mortality could not be commented upon because of the small number of patients. If you look at another meta-analysis, looking at 4 major trials, they came to the conclusion that post-thrombotic syndrome is reduced with intervention. Venous obstruction is also reduced with intervention. However, reflux does not reach level of significance. I want to bring an analogy to avoid misconceptions about modality of treatment. Looking at the Sox trial and its effect on post-thrombotic syndrome. If you recall the Sox trial, which was a randomized trial, a lot of patients in that trial, the authors demonstrated that venous ulcers were not affected by application of compression stockings. Recurrent venous thromboembolic disease was not affected. Reflux was not affected, and the venous disease-specific quality of life was not affected either. Now, I have personal criticism to this study as well. I'm not going to get to those. And based on that, the CHEST guidelines came to the conclusion, which I think is correct, but again, the wrong message was conveyed to the public, not only the public, but educated doctors and providers who take care of these patients. They said that in patients with acute DVT of the leg, we suggest not using compression stockings routinely to prevent PTS. And this was a grade 2B indication. Based on that study, this is correct, but the misunderstanding was phenomenal. The wrong conclusion was that stockings must not be used in venous disease, which is not correct. If you look at the SBC guidelines, there is clear indication of stockings, compression stockings, and almost every provider who is in this field uses them in their patients. It has a 2C indication for post-surgical and endothermal ablations. For sclerotherapy, it still has a 2C indication. For leg ulcers, it's even higher, 1B. And even in cases that you have mixed PAD and venous ulcerations, you can use compression stockings provided you do not have severe form of B, here defined as an A of less than 0.5, or an absolute ankle pressure of less than 60 millimeters of mercury. Now, going back to the published guidelines, ACCP 2012 and 2016 guidelines state that in patients with acute proximal DVT of the leg, we suggest anticoagulant therapy alone over catheter-directed thrombolysis. In my opinion, this disservices the patients and the community at large. However, they do make a neutral comment there. Again, it's not a suggestion. It is not a recommendation. They just put it there, stating that patients who are most likely to benefit from CDT are those who attach a high value prevention of post-thrombotic syndrome. In other words, saying there may be a role for its reduction. A lower view to the initial complex. Now, in this era, we really don't have complex conventional procedure. Many of these can be done fairly rapidly in hands. The costs of bleeding are like to choose CDT over anticoagulation alone. In other words, patients, if they do decide not to have PTS and get better, they will. But again, not a recommendation from the college. If you look at the American Heart Association guidelines published in Circulation 2011, Catheter-directed thrombolysis and other invasive modalities should be given to patients with iliofemoral DVT associated with limb-threatening circulatory compromise, such as phlegmatitis cerulea, and it's a class 1 indication. It is reasonable for patients who have rapid thrombus extension despite anticoagulation, and the 2A class with level of evidence C has been recommended. Society of Vascular Surgery has a similar recommendation. We suggest a strategy of early thrombus removal in selected patients meeting the following criteria. And again, these criteria are truly arbitrary, but since they have used it, they have formed patients. A first episode of acute iliofemoral DVT thrombosis, symptoms of less than 4 days in duration, low risk of bleeding, and ambulation with good functional capacity and an acceptable life expectancy. The same findings are mirrored by Society for Society for Invasive Radiology, or SIR. In JVIR, their major journal, they make the following recommendation. The Society for Interventional Radiology considers the DVT as an adjunct regulation to represent an acceptable initial treatment strategy for carefully selected patients with acute iliofemoral DVT. Similar. So those are the guidelines that we already have. Now, some findings that I believe deserve attention. In my experience, acquired unilateral edema almost always has some form of iliac vein stenosis. Now, you don't have to have DVT for that, but if a patient had equal-looking legs at one time and now comes with one of the legs being larger than the other, he or she has a problem, and probably it's in the iliac venous system. This is one of my patients who was fine before. Over the last few years, he started having swelling of his legs, and his symptoms were dismissed as not being a real threat to life. You don't have DVT, take some diuretics and compression stockings, but his life was miserable. This is another patient, not as much as you can see, but clearly the right side is larger than the left. This has progressed, and the patient has lymphedema. And once you go in and do a venography, now you don't need IVUS for this, although IVUS is clearly indicated, and I would recommend 100% of the time, but you can appreciate the extent of venous damage and how it can be effectively treated with percutaneous endovenous intervention, including venous stenting. This is another patient with similar presentation, and after stents are placed. Now, what is an underdiagnosed concept is the effect of orthopedic hardware. Oftentimes, you see patients who had years ago some form of operation on their hip, knee, or even the vertebral column, and they progressively start having symptoms, and nobody knows why. But once you do a venography, you would recognize that there is truncal vein damage as a result of the procedure. Now, it doesn't have to be a direct insult to the vein at the time of surgery, although it can happen. The inflammatory process that ensues affects the vein date, and we have a very effective and safe treatment for dealing with it. This is another patient, and you can appreciate that the iliac vein has been damaged by the orthopedic hardware here. Another case of orthopedic hardware placement with the patient developing progressive symptoms. If this was the arterial circulation and you look at this, if this was an artery, you would say, well, there is no flow limiting lesion. But in veins, the story is different. And this is actually a significant lesion. It's a diffuse significant lesion. And with IVUS, you can appreciate the pancake effect that resides throughout the course of this vein. And the patient did beautifully after treatment of his iliac venous disease. Now, I would recommend IVUS to every single operator. I wasn't like this before, but now I'm recommending that for several reasons, not just for the patient safety, but for the safety of the operator, because there are individuals who may not know this concept, and they look at this vascular bed and would say, well, there is no problem with this. And that can lead to problems for the operator. That's why for your own safety, it's good to document the pancake effect and the lesions with IVUS imaging. Now, let's say this is another patient who had prostate cancer and got radiation, and you can appreciate the damage that has occurred to the vein, and we have effective treatment with stenting. This is another patient who received an ELG for triple, and months later started to have DVT due to the compressive effect of this hardware on the truncal vein. Now, of experience again, if you do not have IVUS, which you must have all the time, there are hints to presence of stenosis. If there is deflection of your guide wire as you go up, it suggests that there is something wrong with that vein. Either there is a shelf, there is a web, there is something there which is deflecting your wire. If the cephalad diameter of the vein is smaller than the caudal diameter, although it can be subtle, but that points out to significant stenosis. Sometimes you see color flow aliasing, indicating turbulence on external duplex, but you can't rely on external duplex for assessment of the iliac vein. If you find it, so much the better. If you don't, it doesn't mean that the patient doesn't have problems with the iliac venous system. Pressure differences have been reported. Anywhere between 2 to 4 millimeters of mercury difference has been regarded as significant stenosis. If you find it, it is true, but oftentimes you may not even find this pressure gradient. One other observation is that once you initially place a balloon and dilate the balloon, the pain that the patient experiences in the groin area and the back area is actually a good sign of success and a prognosticator that the patient would do well. Contrary to the arterial circulation, you should be wary about perforation and damage to especially the external iliac artery. With the veins, it is a good sign, at least in my experience, that the outcome is going to be good. And if the pain, in some of these patients, the pain after stenting can persist for several days, they are uniformly responsive to a short course of non-steroidals, ibuprofen, naproxen, just for 3 days would take care of this. And the patient would come back very happy. So, in conclusion, from what we have discussed, percutaneous endovenous intervention, including catheter-directed thrombolysis, is alive and well for the treatment of iliac DVT. Those who are doing it, I would advise them to keep doing it. And to the naysayers, I would recommend that they should consider doing it after acquiring proper skills. Now, quoting from Arthur Schopenhauer, 19th century German philosopher, all truth passes through 3 stages. First, it is ridiculed. Second, it is violently opposed. And thirdly, it is accepted as self-evident. So we are waiting to get to that stage. I would like to thank you for your attention and have a pleasant day.